Hello all, my name's Nils Spooner. I'm the chair of the Patient-Centric Sampling Interest Group, who are your host for this webinar today. Thank you all for joining. Our webinar today is brought to you by Nils Vethe and Karsten Midtvedt, both from the Oslo University Hospital. The title of the talk today is Finger Prick Sampling for the Monitoring of Tacrolimus, Creatinine and Hemoglobin in Kidney Transplant Patients. Just a little note from the Patient-Centric Sampling Interest Group, who are your hosts today. We wouldn't be able to bring you these webinars and perform our other activities without our supporters and sponsors who are listed on this slide. And links are, these slides will be available after the event, and links to all these companies are available on our website. Just so you know, we'll do this quick introduction, then the two talks from Nils and Karsten. We'll then have hopefully a good period of time for a Q&A. So to submit your questions, please use the chat function, either the communal chat or the private chat. It doesn't really matter either way. I'll be monitoring that and I'll be posing the questions to the speakers. Please note that the webinar is being recorded and will be available on demand afterwards. And with no further ado, I'd like to go off stage and hand you over to Nils. Thank you.
Okay, thank you, Neil, for the introduction. And thank you for inviting me to this webinar. And I will find my presentation. And I hope that you see this. If you don't, please tell me. So, finger prick sampling after
We can see it fine, Nils.
Thank you. Thanks. Yeah, here you can see a picture of our hospital, Rikshospitalet, at Oslo University Hospital. Just as a disclosure, I have received funding and sampling devices from Kapteiner for research purposes. Okay, home sampling. It's the benefit of home sampling is that it is more convenient and more flexible for the patients. And also it facilitates a better and tighter follow-up after a kidney transplantation. In the hospital, although home sampling may save some resources for ordinary blood sampling, we still need to coordinate and handle the home sampling concept. So it brings also along more complexity in our hospital. And from a laboratory perspective, I think that maybe the first thing that we will think about when it comes to home sampling is the design of a method. We are thinking about how can it be done? How can we do it precisely, accurately, and efficiently? And our next perspective in the lab will probably be how to validate it, how can we implement it, and how can we run home samples on a daily basis, in addition to the ordinary venous samples. To put it in a context, just a brief background for therapeutic drug monitoring in kidney transplant recipients. Probably most of you know that immunosuppressive drugs are used to protect the transplanted kidney against the immune response. And it's important that the immunosuppression it should not be too powerful, and it should not be too weak. So we are performing therapeutic drug monitoring, where we measure the drug concentration in the blood to ensure optimal dosing and thereby adequate immunosuppressive efficacy. When it comes to home sampling and home sampling for kidney transplant recipients, the immunosuppressive drugs are obviously of interest to analyze, and also some biomarkers, and then especially biomarkers for kidney function. At our hospital, we have given priority to the immunosuppressive drug tacrolimus and the biomarkers creatinine and hemoglobin. So I will focus my presentation on those analytes. This is a scheme of a home sample cycle. And here I want to illustrate or give a short view of the main laboratory operations. In the lab, we receive the samples. We have to register the samples in our data system. We are doing an inspection of the samples. And thereafter, we have to do some sample preparation before the analytes are quantified on an analytical instrument. In some cases, we need to do some corrections of the results before we report the results to the clinician. In our studies and in our experience, we have so far worked with Capitainer and Mitra devices. So my presentation will be focused on those two sampling devices. The quality of microsampling itself is key to success. And then it's important to know the critical factors for the specific device you are using. For the Capitainer device, it may seem simple, but one important factor is to hit the inlet with the blood drop. And the next key factor is to have a large enough blood drop when you're doing the sampling. And for the Mitra device, the patient needs to be trained for the technical operations to handle this device. And also it's important to focus on the timing of how you are absorbing the blood into the tip. It's also important that the cartridge is closed carefully afterwards. And as a summary of this, the patient training and acquired skills are crucial for success with the microsampling. When we receive the microsamples in our lab, as I said, we need to inspect each sample. And then it's important that we know what to look for. The Capitainer can be underfilled if the patient are applying a too small blood drop. And the underfilling of a Capitainer is quite easy to detect, because then the filter disc within it will be blank. It will be totally white. So it's a yes-no assessment. But sometimes there may be an incomplete transfer of blood to the filter disc. And then we need to look for a small amount of residual blood in the capillary inside the Capitainer device. The Mitra device, it can be underfilled with too small blood volume. Then we will detect underfilling visually by seeing white spots on the tips. It can also be overfilled, and then we can see darker spots on the tips. But sometimes we also will observe that blood has been applied close to the sampling head on the plastic material. And if you are not closing the cartridge carefully, some blood may be transferred from the sampling head to the inside of the cartridge. So we also have to look there when we are doing the inspections. And in our study, we performed an ad hoc analysis. We looked at does overfilling matter in the mitra tips, and we analyzed 8 overfilled samples, and we saw that this overfilling resulted in 19% too high measurements. So the next thing that we are concerned about in the lab is the analytical methods. When we are doing the tacrolimus analysis, we are using a quiet standard protocol where we add water to the blood, and we add a precipitation solution containing internal standards, and we so it's a simple protein precipitation we are doing, and the supernatant is transferred to LC-MS analysis, and we are running a 2-channel LC-MS instrument with approximately 1 minute runtime per sample. And when we started with the mitra devices, we wanted to have an analytical method that was very similar as our standard method for liquid samples. So we designed the method with the same reagents. We are extracting blood from the tip by using water, and we are adding the same precipitation solution, and we are running the identical LC-MS method. So it's a very similar setup for the mitra samples. We also tried this for the capitainer method, just adding or extracting with water and adding the precipitation solution. But in this case, we observed significant ion suppression. So we needed to look for an alternative. And then we tested another extraction method based on salting out assisted liquid extraction, where we used ammonium sulfate and an organic mixture with acetonitrile. And in this case, we got a cleaner organic phase, and we did not observe any significant ion suppression anymore. So that worked well. Another aspect in our lab is that we use a shared calibrator source for the 3 method setups. And that makes it easier to harmonize the results between liquid blood samples and the 2 microsample methods. So I think that this is one important aspect that many laboratories will meet when they are starting with microsamples. How are we going to include diverse chemical compounds in the assay setup? I believe that if a lab is going to analyze creatinine and tacrolimus, 2 very diverse chemical compounds, and if the lab is going to do these analyses in ordinary venous samples, nobody would think about combining them in a common method. But when it comes to microsamples, then it is getting more interesting to consider a combined method. And that is due to the fact that the sample material is quite limited in the home samples. It's small volumes. So there are different strategies for combining, for example, creatinine and tacrolimus in a common method. You can do it fully or you can do it partially. And you can also decide not to combine them. But the advantages of combination may be that to utilize the sample material better. Maybe you can have less labor, and you can have an overall shorter turnaround time. The drawbacks may be that you need to maintain an extra analytical method in the lab, and you will probably need to have some compromise on the analytical quality and robustness. In addition, you may get some troubles with contamination of mass spectrometers in such combined methods. There is one example, not from our lab, but from a publication in Pharmacology in 2022. It's an example of a fully combined method for tacrolimus, mycophenolate, and creatinine. And as you see, it is possible to do this. You can get quite nice chromatographic peaks, but you get also quite long run times. And you may get a rather nice correlation towards the ordinary venous sample results. In our lab and in our hospital, we had decided to also include hemoglobin in our home sample setups. And it's more difficult to combine tacrolimus and hemoglobin in a common method. So we needed two different extractions anyway. And then we decided that it would be better for us to analyze creatinine in the same microsample spot as hemoglobin. So you see our setup in this figure. We are using one spot or one tip for tacrolimus, and we are using one spot or tip for hemoglobin analysis and creatinine. Hemoglobin is analyzed on a plate reader by a simple absorbance measurement, and we are measuring creatinine by flow injection MSMS. Let's see. Okay. In our testing and preliminary validations, we looked at creatinine not in clinical samples, but in EDTA blood that was applied to the capitainer and to the Mitra device. And we looked at the correlation towards the corresponding plasma concentrations. And as you see in the upper figures, the correlation appeared quite good, both for capitainer and for the Mitra device. But as you see in the lower figures, when we're looking at the deviations, the relative deviations, then we have systematic bias. And importantly, this bias is also concentration dependent on creatinine. And it's due to a false creatinine signal in the samples. So we needed to do some correction for this. And in this setting, we used the equation from the regression fit for correction. So you can see the correction algorithms here on the screen. And thereafter, in our clinical validation study, patients collected samples themselves, and we tried this correction algorithms. And then we got these results. It was not good enough. As you see, we got a mean difference or bias of 11%, and only 75% of the sample pairs were within plus minus 15% difference. Then we adjusted our correction algorithm. We used an algorithm that was based on the actual clinical data set. And as you see, then we are able to get all the differences within the green predefined acceptance range. And we also performed new validation of this correction. And then we included 12 more kidney transplant patients, and they were sampled. Each patient was sampled on 4 different days. And as you see, now also most of the samples were within the green range for acceptance. So as you see on this slide, this is a summary of the tacrolimus results, the creatinine results, and the hemoglobin results. And what we did in our study was that we compared the results when the kidney transplant recipients had performed the sampling themselves against samples that were obtained by healthcare professionals. And as you see here, the results in self-collected finger prick samples were just as good as the ones that the healthcare professionals had samples. So that was probably the main finding in our study. Okay, when we are doing therapeutic drug monitoring, we are measuring the drug concentration, and the drug concentration is changing all the time through the dose interval. And usually we are collecting a sample towards the end of the dose interval. We are measuring the trough concentration. This is not because this concentration has the best correlate to the efficacy or the adverse effects, but it's more like this sampling time point is more easy to implement in practice. But for many drugs, the total exposure during the dose interval will have a better correlation to the clinical outcome. The drawback is that estimation of the total drug exposure, the area under the concentration time curve, is much more demanding to perform in practice because we need more samples. For tacrolimus, there are now quite good documentation for the area under the curve as a good correlate with the risk of rejection in kidney transplant recipients. And there is a suggested cutoff also. So with AUCs, we can better predict the rejection episodes. And it's also possible to estimate the AUC by collecting 3 or 4 samples during the dose interval and using mathematical or pharmacometric calculation for this estimation. And in our study, we also looked at this. We collected blood samples pre-dose and also 1 hour and 3 hours after dosing. And we did this with venous samples and also in parallel with capitainer samples and mitra samples. And then we calculated the AUCs and we compared the results. So then the question was, are finger prick samples okay for tacrolimus AUC estimations? And the answer is that yes, they are. Both capitainers and mitra samples can be used for the estimation of tacrolimus AUCs, and we obtain approximately 90% of the results within plus minus 20% difference compared to the venous samples. So in summary, the analysis of finger prick sample is usually an add-on in the lab. We have to do this in addition to the analysis of venous samples. So it's important to have a focus on efficient assay setups. And of course, also, it is important to focus on precision and accuracy. We need to inspect the finger prick samples visually to ensure sufficient quality. And often it's also important to do corrections of the results before reporting them. And our study showed that we can obtain good results with self-collected finger prick samples. And that is valid for tacrolimus, both trough and estimated AUCs, and also for creatinine and hemoglobin. These are my acknowledgements at the Department of Pharmacology, Transplantation Medicine, and at the Department of Medical Biochemistry. And also, I would like to thank all participating kidney transplant recipients in our study. And thank you for the attention.
Thank you, Nils. Before we go on to Karsten, there's a dialog box on the screen. I don't know whether you can close that. It's blocking the view of part of the slides to people. Okay.
Is it okay?
Well, you've stopped sharing now, so I can't. Your slides have disappeared now.
Okay. Should I share them again, maybe?
So, well, is Karsten going to take over now? Is he in your office?
He is there, and he is ready.
Okay, let's go straight on to Karsten, and then we'll do all the questions at the end.
Okay. Yeah.
We have, okay, that's the correct screen. That looks good. Okay. Can you get rid of that dialog box? We're seeing a dialog box in the middle of.
Okay, there. Yeah, okay.
Oh, but then we lose the whole.
Okay. Then I'm not sure.
I guess we're just going to have to live.
You see my screen now?
Yes.
Is it okay?
Yes, we don't have the dialog box over the top. That's a lot better. Thank you.
Good.
So,
okay.
Thank you, Nils. We'll hand over to Karsten now.
Yep. I'm Karsten Midtvedt. I'm a clinical transplant nephrologist working together with Nils, and I've been asked to address finger prick sampling for renal transplant recipients for the clinical perspective. I'd like to thank you guys for inviting me. You showed some introductory slides, and contrary to you guys, I'm not sponsored by anyone. I have no financial relationships to disclose. Contrary to Nils, I work with live patients, and I don't really care whether the automatic microsample-based LC-MS method is working. I don't care about hematocrit. I don't care whether it's DBS or VAM samples or whether it's EMEA bioequivalent. And when I read articles, you often find that this study was conducted in a controlled environment using a trained nurse to collect the DBS or VAM samples. Well, that's far from my everyday life. I need to get this in to my patient's everyday life. I need to trust Nils when he gets a sample, he says, yes, this is the correct TAC, this is the correct creatinine, this is the way it should be. And that's what I'd like to focus on today. And I'll start with my conclusion. My conclusion is very, very simple. A chain is only as strong as its weakest link. Some of you may be puzzled by that, but you'll understand in 15 minutes from now. in the invitation, it says finger prick sampling for the monitoring of tacrolimus, creatinine, hemoglobin, and kidney transplant recipients. I don't know how many of you are transplant nephrologists, how many of you work in the lab. Nils showed you a little bit about background for kidney transplantation. I'll just have to go through that very, very briefly before I go on. Following a kidney transplantation, you need lifelong immunosuppression. There's absolutely no drug holiday. You can't say, hey, it's Friday, I forget my drugs. You can't do that because then you'll have a risk of a rejection and lose your graft. Currently, 90 to 95% of kidney transplant recipients worldwide are on a combination of prednisolone, tacrolimus, and mycophenolate mofetil. For tacrolimus, it's mandatory, as Nils has showed you, to do therapeutic drug monitoring. And we usually measure trough values, and we have therapeutic windows. If you're overdosed, there's risk of rejection, of cancer and infection. If you're underdosed, there's a risk of rejection and losing your graft. Following a transplantation, you need lifelong follow-up, usually by nephrologist, often a transplant nephrologist. Depending on how you introduce TDM will depend on where in the world you're living. I live in Oslo in Norway. We're a small country with 5.4 million inhabitants. What's that? Half of London's inhabitants. I think there's approximately 9 million people living in London. But I work and live in Oslo, and let's just, for the fun of it, put Oslo in the middle of Germany and show you the distances we actually have from our center to the northern parts of Norway where some of my patients live. And I don't imagine too many people in Germany wanting to have people coming from northern UK or down in Romania or southern parts of Spain. There were also some Americans listening, at least I was told, and you don't know much about European geography. So let's put in Rochester, the Mayo Clinic. This is the distance we're covering. It's a long area. It's a long place to travel. And we're one transplant center. So once the patients are here, they stay here for a while. You say 1 week in the hospital, plus minus a couple of days maybe. Then they spend 7 weeks at a nearby patient hotel. They go to regular checkups in an outpatient transplant clinic 2 to 3 times per week. We have blood tests where we measure creatinine, hemoglobin, tacrolimus, mycophenolate, electrolytes, and then they have a consultation at 10 a.m. Everything is okay, come back in 2 days or 3 days. If it's not okay, you have to go away and do something the same day or maybe tomorrow. After 8 weeks, they go home. Lifelong follow-up by local nephrologist. Eventually, a minimum 4 checkups per year. And every time you measure immunosuppression, graft function, i.e. serum creatinine, blood pressure, etc. So why do I spend time telling you this? Well, in Norway, we have long distances. I just showed you that. The possibility for kidney transplant recipients to receive information and training on finger prick home sampling while in Oslo is an ideal setting for successful finger prick sampling implementation. But maybe we have some weak links. Maybe. What challenges am I talking about? When a patient takes a blood test in the hospital, we have the results within 2 to 4 hours. Intuitive gives us that. We know that the test is correctly taken. We know the time point. There's virtually no time spent on transportation. Analysis can start right away. Definitely the quickest way to get an answer. But it's time consuming for the patient living at home, have to be away from work or school. Maybe parents have to follow the kid if he's underage. It's very impractical, reduces health-related quality of life. And that's the question. Could finger prick home sampling solve this? You will have different things to evaluate. You have to look at the patient and the patient characteristics. Is the patient willing, and does the patient have the ability? Tacrolimus gives a lot of patients shaking as unwanted side effect. Are they able to take mitral or a capitainer? Are they able to perform it? We've tried this out, patients aged 10 years to 74 years. And so far, no one has not been able to do it. But it's very, very important that they get adequate education and training sessions under supervision. You need to have evaluation in the hospital with simultaneous venous punctures. You need to have evaluations of self-taken home samples versus same-day venous samples. They can sit in our lobby and take a home sample and then go and have a venous sample. So these are some of the challenges you have to evaluate. In Oslo, we're really, really lucky. We have dedicated and really interested healthcare providers. All patients interested in home sampling receive face-to-face oral information and personal hands-on instruction, in addition to written information, plus links to 2 YouTube videos that are made in Norwegian by our healthcare providers. They can look at them over and over again. They take a little over 60 seconds to watch, and they can see if they forget, how am I to do this? Sorry. As Nils told you, we use capitainer and mitra. That's because some patients prefer to drip on their blood. Some like to have their blood sucked. So we call them drippers and suckers. And we need both. We need to use both. It's important that we can offer this to our patients. All patients are informed to remember to write down correct date and time of sample. And if we're doing therapeutic drug monitoring, they must remember to write time of intake of last immunosuppressive dose. Determining exact concentrations in small samples is complicated. And we instruct our patient, if device is over or underfilled, as Nils told you, take a new, throw it away. Don't believe it's okay. And when doing TDM, the patients are reminded of TTT, time. It's extremely important. Otherwise, you lose the concentration and it's worthless for you in evaluating the patient. There are many different devices. They're probably equally good. I don't know. We've chosen these 2, and I think you should have 2 different when and if you're doing this. If you have patients that are willing and they're educated, then that's the next chain. It's transportation. It's often unknown. Sent by snail mail, it takes time. Samples get lost. There's studies from the Netherlands where a lot of samples get lost. Stability issues depends on type of DBS or VAMS. You could start using courier services. That's way too expensive with our distances. And drones might work in the Netherlands, but will definitely not work in Norway. In the lab, they need to be interested. Nils and his lab is really interested. And now they're offering dry blood spot analysis every regular workday, not in the weekends. They have regular evaluation versus whole blood analysis. They have correct storage, and the personnel is interested in the procedure. So for us in Norway, transportation is definitely the weakest link. We struggle with solving that for patients living away from the city. Outpatient or sampling by DBS or VAMS can be offered for patients living long ways from the hospital, because they can obviously take their home sample with them for tacrolimus the day they're going to the doctor. They don't necessarily have to get up at 4 o'clock in the morning and drive 150, 200 kilometers to the nearest hospital to have a vein puncture, they can come in the afternoon and bring the tacrolimus. That can be analyzed that afternoon or the next day. If you have busy patients or parents, it's very practical. If we change the dose of tacrolimus and we need a new therapeutic drug monitoring, it might be a hassle for the patient to come to the hospital. You say, hey, take this Capitaine or Mitra with you and send it to us 3 or 4 days from now. We can look at it. If you start a new treatment with drugs you know interact, obviously it would be interesting to have a new monitoring of tacrolimus. If a patient has diarrhea, you actually lose a lot of water, but you increase your tacrolimus, contrary to the belief of many people. So a new monitoring during diarrhea is important, and definitely do not want the patient in the hospital. During contagious infectious diseases or ongoing pandemics, we started doing hemoglobin and creatinine at the start of the pandemic of COVID. Unfortunately, we were not able to finish it so that we really could include patients, because we wanted to have them staying in their patient hotel instead of coming into the hospital. Maybe every second visit could be by dry blood spot. Adolescents, that's a challenge. 50% of graft loss in adolescents are due to non-adherence. We've done studies showing that they get more responsibility over their own life by doing home monitoring, and they like doing home sampling, and that can increase their everyday life. Currently, we have 20 to 30 patients, adolescents between 14 and 25 years, going in an outpatient clinic, and half of them prefer to do dry blood spot for measuring of tacrolimus. They come in the afternoon, 3 o'clock, there's pizza, soda, play cards, ping pong, and they bring their TAC from the morning, and then they can have the rest of the lab results taken that afternoon, and everything works fine. It increases adherence. It also increases or makes it easier to tailor or personalize the dose by doing 12 or 24-hour AUC monitoring, as Nils sort of told you. Currently, we have implemented our finger prick home sampling in some patients living in rural areas and some urban areas. Patients have been educated here from way up north, living 25 miles, which is 200, 250 kilometers away from the hospital. They take their tacrolimus in the morning and bring them with them. And then they take the rest of the blood tests at 2 or 3 p.m. and then have a consultation with the doctor. Just told you about the adolescents and young transplant afternoon clinics at Oslo. It works. They like it. TAC AUC measurements in patients with rejection infections. We perform them. If a patient comes in with rejection and has a TAC that's adequate trough, we tell them, hey, we need a measurement 1 hour and 3 hours afterwards, and then we can calculate your AUC. Or the other way, if he's over immunosuppressed, we can do the same. We've also done TAC AUC measurements during research with Patramere, IXL, GFR, and it works. Since 2018, we've been looking at coefficient of variation. All our patients come to 1 year consultation following transplantation. Then they get educated in DBS, and they get with them 3 to 6 mitras, which they take the coming weeks, just to look at coefficient of variation, which correlates with graft survival. This winter, we're hoping to have every second visit at our house during those first 8 weeks for the newly transplanted patients by home or hotel sample, where we can measure TAC, creatinine, hemoglobin, and maybe even mycophenolate mofetil. Nils is working on that. So self-performed finger prick sampling will lower number of hospital visits, reduce patients' burden, i.e. more efficient, less time consuming, improve an individualized tailored immunosuppressive dosing, leading to longer graft and patient survival. And that's why I worked with this. Will improve quality of life for the patient and maybe in the end also for the treating physician. It could reduce healthcare costs. So far, it does not, at least not in Norway, because I have to pay for these devices, and there's no way I can get that refunded by Social Security anymore. So the chain is only as strong as its weakest link. You have to have the patients that are interested. They need education to take the blood sample. You have to have transportation working. You have to have a laboratory that interested. But is there an additional link here, maybe? There is a missing link here. And you need a dedicated transplant nephrologist or a dedicated physician. If you don't have that, you will never get DBS up working. Thank you for your attention. I think me and Nils will be happy to answer any questions.
Thank you, Karsten. That was fantastic. Really, really interesting. And Nils, I don't know whether you're able to sneak into the frame as well to help answer the questions here as well as Karsten. Is Nils Tor still in the room?
Yeah, he's here.
I'm here.
Okay, I can see him in the background now. He's
much
out.
brighter than me. He can answer all the questions. I can just sit around.
So we've got some questions that are around the analytical method and some that will be more for you, Karsten. I'm going to go back to the top, but some it's quite helpful. Some of the participants have been answering the questions as they go along, so I'm not going to read them all out. One question here from Philippe, and this is for you, Nils Tor. How is the analysis done in the lab? Is it necessary to have specific equipment and methodology, or can the analysis be done by any lab facility?
Yeah, I think that you need to have a lab that have LC-MS equipment. If you have LC-MS equipment as your standard infrastructure, then I think it would be rather easy also to implement home samples in your setups. But if you don't have such equipment, then it may be a little more tricky, I think.
Yeah.
Mm.
Do you have any more data from the study participants about their actual their thoughts, their concerns about home sampling, whether they wish to switch to home sampling? Do you have any data on that at all? I know you talked in general terms, but did you do any questionnaires at all?
Nils Tor and I published this article. I don't know if you still see our slides.
Yeah, we can see your slides.
Yeah, we didn't ask them if they like to do home sampling. No. But we've performed a small study on medical inhalers as a challenge, which is a challenge in solid organ transplant adolescents. We performed a feasibility study of 22 kidney and combined solid organ transplant recipients that were 18 years of age, 17.9. And they were instructed in home monitoring of TAC using Mitra in combination with the daily use of a app we call Tusen TAC, which in Norwegian actually means thank you. Very simple design. They were just educated very briefly, and then they were followed at home, 1 weekly TAC measurement, and used our app, which also has gamification in it. And it increased adherence. It was feasibility. And we asked them, and home sampling was feasible and preferred by all compared to attending the outpatient clinic. One of the participants commented, however, that I might not be preferred when newly transplanted. Then it feels safer being at the hospital. In this unadherent young population, 90% of the DBS were obtained correctly, which shows us once they get the responsibility in their hands, they're able to do it. I mean, this was way above what we thought would come out of this. But it's a very, very small study, so we need to do more. We planned to do a much larger study, but then there was a pandemic in Norway. I don't know if you've heard of it. COVID-19 kind of made it difficult to have patients coming in and out of the hospital. So we haven't done that yet.
Okay, that's really interesting. Thank you. Just, I love the term drippers and suckers. Do you have a feeling of the proportion of those that prefer dripping and versus those that prefer sucking?
No, I think you need to offer them both. I think you need to show them both and say, hey, this is what we have. Which one do you like? And if you're really shaking your hands around so you can't even hold your cup of coffee, it's very, very difficult to get that drop of blood to hit the capitainer. I'll tell you that. It's easier with the metra tip then. But it varies from patient to patient. So no. Really, we don't really know.
Okay, thank you. Just there's a few questions about the creatinine assay. One asking whether it's flow injection, and one asking how you ensured that the creatinine didn't run through the column in the dead volume. So, two different assumptions there. One's thinking there's a column involved, one's thinking there's not a column involved. So maybe if you can just give a little bit more detail about that creatinine method.
Yes. The challenge with creatinine is that it is so polar. It's such a polar compound, so it's difficult to run it on reverse phase chromatography. And you see that many are still doing it or trying to do it, but often you will have almost no retention on the analytical column. So that's why we decided to bypass that challenge or problem, and we decided to instead perform a flow injection analysis, and then we are not using any column at all. So we're just injecting the supernatant in the mobile phase flow, and then the mobile phase will go directly to the mass spectrometer. And the reason why we can do it is due to a very, very high signal for creatinine in the mass spectrometer. So that means that we can dilute the samples several thousand times before we inject it. So we are injecting a very small biological a very small volume of biological material in the mass spectrometer.
That makes a lot of sense. Do you know whether you get any, do you use a stable labeled internal standard as well with your flow injection?
Yes, absolutely. And we are using the stable isotope internal standard already during the extraction step. So the extraction solvent, when we are extracting blood from the microsample, already contains the internal standard, and I think that is critical thing to do.
Thank you, Nils. I think this question is probably for Karsten, just around more frequent sampling, just whether that has decreased the ill effects of tacrolimus on the pancreas, for example. Does frequent monitoring allow us to better control these effects?
Well, and frequent monitoring allows us to control for unwanted side effect, but it needs to be correctly taken. It's interesting if somebody's asking about pancreas transplantation. For a long time, a pancreas transplantation, this is they measure blood glucose, they're really good at measuring and doing home sampling. They've been doing it for 10, 15, 20 years before they get pancreas transplanted. And looking at C-peptide, i.e. insulin, versus creatinine versus blood glucose, you can calculate a number, and a change in that number could tell you that something is going on in this pancreas graft. And we actually have a group now working on this so that previous pancreas transplant recipients actually can have home sampling once every 2 weeks, because then you might be able to catch something going on in the pancreas before they realize themselves that the blood glucose is elevated and it's too late, because the rejection is already there and it's very difficult to stop. So we have a group now. We're working approximately a year with C-peptide and creatinine from Natura and glucose on dry blood spot, taken at home, and we will put this into system hopefully sometime next year.
Okay, thank you. Couple of quick questions, and then I guess we've run out of time. How many samples do you analyze a month, approximately?
How many samples we analyze? Yeah. At this time we are analyzing tacrolimus in our routine from the home samples, and I think that we have between 10 and 20 samples every week.
Okay. Thank you. And just the last question for the creatinine assay. Do you analyze the creatinine as whole blood creatinine, including the intercellular creatinine?
We measure the whole blood creatinine, yeah, and it actually the whole blood creatinine correlates very well with the plasma creatinine.
Okay, thank you very much. I think we've run out of time. If you don't mind just stopping sharing your screen, please, because I just want to quickly show people a couple of slides to do with the patient-centric sampling interest group.
Yeah. Like that.
Perfect. And I need to now find my slides. There we go. So just for people that are interested, this webinar was brought to you by the Patient-Centric Sampling Interest Group. We have a number of activities around these kinds of alternative sampling technologies that put the needs of the patient at the center. We're a free-to-join group. If you're interested in joining the conversation, please join our LinkedIn group, which is the QR code at the bottom right there. You can take a look at our website, which is the upper QR code, and find out a lot more information about what it is we're doing in the Patient-Centric Sampling Interest Group and how you can get involved. There's a summary of the things we're doing there. Again, I'd just like to thank our sponsors who make it possible to bring you these webinars and our other activities. And with that, I'd like to thank our speakers again, Nils, Tor, and Karsten, for an absolutely fantastic pair of presentations. We got a lot of engagement here. A large number of people were logged on. A lot of interesting questions, some great discussion here. And what you're doing is really important and really exciting. So thank you for sharing that. I think what you're doing there in Norway is phenomenal. And hopefully a lot of people have learned from this. And hopefully we can see a lot of this being adopted by other people. So with that, this is our last webinar of the year. Our next one is towards the end of January. And I wish everyone a really fantastic Christmas and all the best for the new year. And with that, say goodbye. Thank you, everyone.